And after the Parley boy and the Phalanx baby, I'm going to speak to you about some fractures. Some of the other regions are going to be spoken about by other legends who are sitting here. And this is what was left for me to talk. And I'm going to talk to you about a short story of my experiments with P1 shaft fractures. So this was a young gentleman around 30 years old, a direct injury, skin is lacerated, bone is fractured, so obviously something in between was also lacerated, had an extensor tendon laceration. I needed to choose a method which would allow me to treat the tendon injury appropriately as well. And the best thing that I could think of at this point was an intramedullary compression screw, much like a scaphoid fracture. There is not much difference between this head fragment as compared to, say, a proximal pole of the scaphoid. So why not fix it that way? And this allowed me to repair the extensor tendon well and go ahead with the extensor tendon rehabilitation. So stable fixation for the purpose of treating tendon injury. Not so lucky this time. This was a motorcycle accident, came at the peak of COVID pandemic. And I was wondering what to do for this. And this open wound on the volar side had the flexor tendon actually going through the fractures. It was interposed, the pulley structure was completely destroyed. And this is what I did. I just decided to create a very stable base for this commutative phalanx to move. And the phalanx was treated only by meticulous soft tissue repair. I just repaired whatever soft tissue I could cylindrically around the fracture and I left it to heal, knowing fully well that this might require some secondary reconstruction. And this was him at 3 months. It's a united fracture. It's grotesque looking, but the function is good. He has an extension lag and a flexion deformity. Sonography tells me that there is an extensor tendon adhesion as well as the central slip is divided. So he is now scheduled for extensor tendon tenolysis and repair, and of course there will be a skin contracture release that also will be done at the same time. This was another patient who I saw very recently, and he was just 2 days old. He's in his 30s again. And on presentation, this is without any anesthesia, he could move this much in the OPD, more than 50% movement. There's some amount of pseudocloying that you can see in the index finger. And when they move so well, more than 50% of active movement without any anesthesia, and the fracture is well aligned, there is no deformity, I think this is a very strong case for conservative treatment. So I instantly knew I had to just buddy tape him. And then, of course, after you tape, you again check the alignment and you ask them to move again. And again, when he was extending, there was some amount of pseudocloying. So again, I knew I don't want to allow him to extend too much, so I would put him in a slab. Again, move. I think that there's one mantra for phalangeal fractures is you should be able to move them early, no matter what treatment you choose. You could choose plates, you could choose intramedullary wires, but what is important is move it. If you don't move it, you are going to lose it. So you could use intramedullary K wires, ball and bandage, whatever. At the end of it, you have to just say, will I be able to move this early enough to prevent flexor tendon adhesion? That's the method that you need to choose. Thank you very much.